Presenter is David Cescon from the Princess Margaret Cancer Center, and he'll be talking about novel epigenomic targets in triple-negative breast cancer. I'd like to remind the audience that at the end, we'll have a question and answer session in person, but also you can submit questions online.
Thank you, and good afternoon to everyone here and to those who are joining remotely today. I'd like to thank Dr. Merrick Bernstrom for inviting me to give this talk today, and to the organizers for holding the session in this virtual and hybrid format, which is so far working very nicely. Just waiting for my slides to come up. As was noted, I'll be discussing today epigenetic approaches for triple-negative breast cancer, and I think there are some nice themes that tie into my presentation that were discussed in the earlier presentation, so hopefully should give us some nice food for thought in the discussion period that will follow. There we go. Here are my disclosures. So the outline of what I will cover in the next 30 minutes or so is to first provide a bit of clinical context for drug development in triple-negative breast cancer, which I think we all understand is a challenging area of remaining unmet clinical need. I'll provide several examples of epigenetic drug development in triple-negative breast cancer, including some discussion of immunotherapy and epigenetic combinations, which follow on some of the themes that we heard about in the last talk. So if we rewind 5 years, in this review by Dr. Bianchini, we have a nice overview of the clinical development that was happening in triple-negative breast cancer in 2016. Importantly, at that time, chemotherapy represented the only approved therapy for triple-negative breast cancer, and no targeted therapies existed. A number of different strategies were being pursued. Fast forward 5 years, and an update in a really beautiful review recently published in Nature Reviews Clinical Oncology by, again, Dr. Bianchini, provides us with new context where we now have multiple approved therapies for triple-negative breast cancer, which have influenced our clinical practice and are influencing the outcome of this patient population. So this, of course, includes chemotherapy, which remains an important backbone of our therapeutic approaches, PARP inhibitors, which have now been approved for germline BRCA-related triple-negative breast cancers, approvals of PD-1 and PD-L1 immune checkpoint blockade in combination with chemotherapy in the first-line treatment of metastatic triple-negative breast cancer, and also with pembrolizumab and chemotherapy for early triple-negative breast cancer. And the TROP2 antibody drug conjugate, sacituzumab govitecan, which is now approved for chemotherapy-resistant disease. And with these advances, we're seeing many continued efforts to try and both maximize the impact of these available therapies and to develop new strategies through a variety of pathways. Again, it's important to remember that pre-treated triple-negative breast cancer is a clinical challenge. And if we reflect on the standard of care arm, the treatment of physician's choice that was included in the ASCENT trial, which resulted in the approval of sacituzumab for chemotherapy-resistant disease, we can see that the treatment of physician choice unfortunately performed extremely poorly. So those chemotherapies that we would typically resort to, eribulin, vinorelbine, capecitabine, gemcitabine, all of these had response rates of around 5%. And the duration of response and progression-free survival was very poor for all of them. So this background representing our previous best treatment options needs to be taken into consideration when we consider the natural history of pretreated triple-negative breast cancer, which will be the clinical scenario where new agents, such as epigenetic strategies, are going to need to be developed. So moving on towards available epigenetic strategies, we have a growing menu of epigenetic targeted therapies, or epidrugs, as they're sometimes referred to, that are in preclinical and clinical development. Nicely reviewed here in the article cited, these target readers, erasers, and writers of various epigenetic marks. So in the next several vignettes, I will discuss a few of these targets and how they have been pursued as relevant to triple-negative breast cancer. Importantly, as epigenetic regulators of the cell, many of these tie into those other pathways that are critical to the biology of triple-negative breast cancer. So first, we'll discuss PRMT5, so protein arginine methyltransferase 5, as a potential epigenetic target, which has been associated with the regulation of TNBC pathways and potentially TNBC vulnerabilities. So PRMT5 is involved in regulation of is a methyltransferase which regulates both histones as well as other proteins in the cell machinery, which can influence splicing regulation. We just heard a nice discussion about splicing, but can also potentially influence other proteins involved, for example, in DNA damage repair. So a number of potential pathways where such a drug might act. Interestingly, this target, PRMT5, was identified as a synthetic lethal target for tumors with loss of the enzyme MTAP, which is in a genomic locus in approximation with the important cell cycle regulators, CDK, N2A, and B. And this region is deleted commonly in solid tumors and is deleted in some, not frequently, but is deleted in some breast cancers as well. The reason why this confers synthetic lethality with PRMT5 is that the loss of MTAP results in an accumulation of this substrate, MTA, which inhibits PRMT5 and thus reduces the normal activity of PRMT5, and thus further inhibition of PRMT5 or loss of PRMT5 ablates that function and increases the toxicity of that therapy. Multiple PRMT5 inhibitors are in development from a variety of biotechnology companies, and some have entered into the clinic. This GSK drug, whose clinical development I will briefly touch upon, has shown preclinical activity in some breast cancer cell lines, as shown here. Again, various levels of toxicity as measured by IC50 or a growth versus death metric. And interestingly, in this paper, suggested that sensitivity was actually associated with the retention of wild-type P53, so perhaps not something that's common in triple-negative breast cancer. Nevertheless, this drug has been evaluated in a phase 1 study, which included an expansion cohort of triple-negative breast cancer. And while we actually don't have the data available specifically for the triple-negative breast cancer cohort, I wanted to, again, provide this as a vignette for how development of such an epigenetic agent could proceed. So this was a phase 1 dose escalation study conducted in patients, as usual, with advanced solid tumors which were refractory to standard therapies. Following identification of the recommended phase 2 dose, a number of cohort expansions were pursued, which again included both triple-negative breast cancer and here also ER-positive breast cancer, following prior treatment with CDK4/6 inhibitors. As was emphasized in some of the earlier sessions in this meeting, we know that CDK4/6 inhibitor-resistant ER-positive breast cancer is also a significant therapeutic challenge. As was nicely shown in this study, the PRMT5 inhibitor had the pharmacodynamic activity that was expected based on alterations in the symmetric dimethyl arginine, which is measured here both in tumors and in plasma. So the drug is hitting the target and achieving its intended epigenetic impact. What are the toxicities of these type of agents? As is seen with many epigenetic agents, the toxicities observed are relatively non-specific side effects, which include GI, and here nausea and vomiting, as well as some hematologic effects, anemia here present in about half the patients. So here's a study where activity in TNBC was evaluated, but it has not yet been reported. But interestingly, is continuing to be developed now in the context of ER-positive breast cancer with a window of opportunity study underway. Having not seen the data, we can't conclude that there was not activity in triple-negative breast cancer. However, there may be improved opportunities to identify triple-negative breast cancers in this heterogeneous disease, which could benefit specifically from such a strategy, or perhaps by a strategy of targeting PRMT5 in a different way. And indeed, this PRMT5 inhibitor that has been recently described, MRTX1719, targets not the PRMT enzyme itself, but PRMT in combination with the MTA substrate, and thus permits perhaps improved opportunity to address the synthetic lethality of MTAP loss. And indeed, in this collection of preclinical models, we can see that this agent demonstrates significant sensitization in MTAP-deleted models to a greater extent than is seen with the other PRMT5 inhibitors. So here, again, triple-negative breast cancer not represented, but recognizing that MTAP may be lost in a small subset of triple-negative breast cancers, perhaps this is a need to focus the development of such agents. In addition, other opportunities may exist to target PRMT5, and here, the development of type 1 PRMT inhibitors have shown to be synergistic in combination, and thus provide additional opportunities for development of combinations where single-agent activity may be more challenging. So moving on to epigenetic therapies in combination with chemo or targeted therapy. Indeed, epigenetic monotherapy is perhaps a challenging strategy for this aggressive disease, and we know that chemotherapy and other targeted therapies, including PARP inhibitors, have an existing role. So here I'll be discussing BET inhibitors in combination with PARP inhibitors, but we'll begin first by considering the role of epigenetic control in the sensitivity of triple-negative breast cancer to other therapies. So BRCA is a recognized feature of some triple-negative breast cancers, certainly those that are related to the presence of a germline BRCA1 or BRCA2 mutation, but BRCA is not restricted to those tumors with germline alterations, and there's been a great effort to define and identify this feature such that it might guide the use of therapies such as platinums, PARP inhibitors, or other DNA-damaging agents. This genomic signature, HR-detect, that has been described based on the pattern of somatic alterations in a tumor based on whole genome sequencing, has been shown to identify those tumors that contain germline BRCA alterations, but has also been shown to identify tumors that have somatic alterations reflective of BRCA1 and 2 loss, which includes both mutation and methylation of BRCA. And we can see here that tumors based on, in this large collection of 560 breast cancer samples, that the tumors with high HR-detect scores include, again, a subset that have evidence of BRCA methylation. So is BRCA methylation a marker of response to our known DNA damaging agents? Platinum, for example. And indeed, this was examined as part of the TNT study, which compared first-line carboplatin to first-line docetaxel in patients with either germline BRCA-related or triple-negative non-BRCA-related breast cancers. And as was shown in this study, importantly, that in germline BRCA carriers, carboplatin had a substantially increased response rate as compared to docetaxel. The presence of BRCA methylation did not predict for an increased response to carboplatin versus docetaxel. And one hypothesis here is that this methylation that was performed on archival samples may not reflect the current status of BRCA activity in these metastatic tumors. We know that olaparib, PARP inhibitor, monotherapy activity in breast cancer is primarily limited to germline BRCA-related tumors. Here, initial data from the olaparib study in breast and ovarian cancers, a phase 2 study published 10 years ago, showed that the tumor responses occurred only, or almost exclusively, the responses were exclusive to germline BRCA cases. and that breast non-BRCA tumors did not respond. We now know that in larger groups of patients, there is activity in some non-germline BRCA carriers with PARP inhibitors, and that includes, for example, in tumors that have other HRD alterations, such as PALB2. But one question is there a way to sensitize breast cancers to PARP inhibitors through the use of epigenetic approaches? This study looked at a variety of epigenetic agents to identify potential opportunities for such epigenetic and PARP-based combinations. Screening these agents resulted in the identification of BET inhibitors as a sensitizer to PARP inhibitors in a number of triple-negative breast cancer cell lines. What they were able to show is that not only is synergy evident, but that the BET inhibitor results in reduced expression of BRCA and other DNA damage-related proteins, and increases the generation of double-stranded breaks that are expected of a PARP inhibitor. These effects extended into an in vivo model, as shown here. The concept of combining a BET inhibitor with a PARP inhibitor has been extended to the clinic in this study of Zen 3694 and talazoparib, results of which were presented at this meeting last year. This was a dose escalation and expansion study in patients with triple-negative breast cancer who did not have germline BRCA mutations. The patient population, as shown here, consisted of patients who had had prior treatment for their metastatic disease and almost all had prior anthracycline or taxane treatment, but a relatively small number having had prior platinum. Again, this is a non-BRCA population, and certainly the anthracycline and taxane chemotherapies would take priority. The dose escalation and establishment of the combination tolerability here involved also not only increasing the dose of the BET inhibitor, but also the need to modify the standard dose of the PARP inhibitor, talazoparib, such that the MTD, or recommended phase 2 dose, was identified at 0.75 milligrams rather than 1 milligram per day of talazoparib. Here's the activity of this combination that has been reported, showing a significant overall response rate of 29%, complete and partial responses, in a population of patients where BRCA1, 2, and PALB2 mutations have been excluded. See, one of these responders was found to have a somatic BRCA1 mutation. The swimmer's plot here shows that some of these responses were quite durable, with here going out to 40 weeks, with patient continuing on treatment. And thus, certainly interesting clinical activity where we would not expect monotherapy activity of a PARP inhibitor. Again, this is an expansion study in a selected cohort of patients, and one interesting feature here is that while the duration on therapy seems longer than the prior duration for many of these patients, a number of these patients had very long durations on their prior therapy, which is not necessarily expected for triple-negative breast cancer, where, as I alluded to at the beginning, the typical progression-free survival is very short. So there may be something selected in this patient population, which may also relate to their response to this therapy. Clearly, understanding the potential of this combination will require characterization in a broader population, and ideally, characterization of a potential biomarker of the combination response. Again, we have a clear understanding of response biomarkers for PARP monotherapy, and understanding how this combination could be directed towards a specific patient population would obviously have substantial value in its subsequent development. In addition, the understanding of the tolerability impact of this combination will be very important. Again, recognizing those additional toxicities that the BET inhibitor confers, and the importance of quality of life while managing metastatic disease in this population. Furthermore, given the data that supported this and the increasing number of DNA repair targeted therapies that are becoming available, one could consider whether such a strategy might be relevant to other DNA repair targeting therapies. I'll move now to another vignette which examines the potential role of epigenetic therapy in targeting acquired drug resistance. Here, the identification of an induced vulnerability to EZH2 inhibition in the setting of paclitaxel-resistant triple-negative breast cancer. This work was conducted at Princess Margaret, led by Dr. Matthew Lupian, a scientist who I collaborate with. So this work focused on the common clinical problem of taxane resistance, which is encountered in triple-negative breast cancer and other settings, and involved the generation of in vitro cell lines with resistance to paclitaxel by chronic and increasing exposure. The specific focus of this study initially was to characterize metabolic adaptations in these cells, and by comparing the drug-resistant versus parental cells, identified alterations in methionine metabolism, including reductions in these important metabolites, SAM and SA. These being relevant to the methylation, epigenetic regulation and methylation of DNA, led to their characterization, and comparing the parental cells to their resistant counterparts, identified substantial changes in DNA methylation across the genome, including specifically reductions in line 1 methylation. Again, repetitive elements that we heard discussed in detail in the previous talk. Interestingly, while DNA methylation at these repetitive elements was reduced, there was a compensatory chromatin modification in the same regions which modulated or compensated for the transcriptional control that was lost. Recognizing that these changes in chromatin modifications can be targeted with EZH2 inhibitors, an EZH2 inhibitor, UNC199, and a inert counterpart, UNC2400, which does not have EZH2 inhibitory activity, were evaluated in these cells. And as we can see in the resistant cell, but not in the parental cell, measuring double-stranded RNA, again, a potential driver of this viral mimicry response that was described previously, UNC1999 induces double-stranded RNA specifically in the paclitaxel-resistant cells, suggesting, again, a potential druggable epigenetic vulnerability that has been acquired with the development of paclitaxel resistance. Looking at the effect of UNC1999 on the proliferation of cells, here cellular proliferation in either one of the resistant pairs or in the parental counterpart, where we see no activity, but induced sensitivity in the context of resistance. This induced vulnerability extends to patient-derived organoids. Here, a sensitive and resistant model, where the resistant model shows specific sensitivity to the EZH2 inhibitor, and also into patient-derived xenografts, which are either sensitive or resistant to paclitaxel. So here, again, extending on the notion that epigenetic control influences sensitivity to chemotherapy and can do so during the process of acquired drug resistance, provides a potential opportunity for therapeutic evaluation, where one could consider a specific population of taxane-resistant triple-negative breast cancer and potentially use the identified epigenetic alterations to select those where such a therapy could be evaluated. Finally, I'll turn to the question of combining epigenetic therapies with immunotherapy. We know that immunotherapy now has a role in the treatment of triple-negative breast cancer, but that in the context of metastatic disease, this is only relevant to a minority of patients, currently based on the expression of PD-L1. And that such immunotherapy is used in combination with chemotherapy, and that immune monotherapy strategies don't currently have a role. As we heard, epigenetic control can influence both cellular intrinsic and tumor intrinsic and immune-based mediators of immunotherapy. Several strategies to evaluate epigenetic agents in combination with immunotherapy have been pursued, and I'll describe two here, which provide, I think, some insights and perhaps lessons that we can reflect on as future such strategies are pursued. So here, the HDAC inhibitor entinostat, which has been shown preclinically to sensitize to immune therapy and has well-documented effects on regulation of T cells, was evaluated in combination with atezolizumab in the TRIO-025 study. This study randomized patients to the combination of entinostat with atezolizumab versus placebo and atezolizumab, and was reported at ASCO last year. The patient population who were included were patients with metastatic triple-negative breast cancer who had had prior therapy. Here, the majority of patients having had one prior line of therapy, but some patients more heavily pretreated. We know from prior studies of immune monotherapy in triple-negative breast cancer that the response rate expected for PD-1 or PD-L1 monotherapy is low, on the order of 5 to 10% in this population when unselected for other factors such as PD-L1. The toxicity of this combination is important, again, to consider. We know that immune monotherapy in breast cancer and in other cancers is very well tolerated with a low rate of serious immune-related effects, but very few other symptomatic toxicities for those patients who do not experience immune-related effects. The addition of entinostat here resulted in increased toxicity, as is, again, recognized for HDAC inhibitors. Here are the results of this randomized study, and again, the randomization is important, where we know that response rates to checkpoint monotherapy are low, and that the patients often enrolled in small single-arm phase 2 studies can be selected and perhaps exhibit higher response rates to the investigated therapy without a contemporaneous control group. And so here the randomization adds considerably to that evaluation. While the overall response rate was higher in the entinostat and atezolizumab group, here at 12.5% versus 2.4%, we can see that unfortunately very few of these responses were durable, and that while the numeric response rate seems higher, there's no statistically significant difference, and certainly neither of these overall response rate estimates differs significantly from what we would expect from atezolizumab monotherapy in this setting. So here we have a negative result for this study, without a clear understanding of the reasons for failure. Was it because of the patients who were enrolled? Was it because the entinostat did not achieve its intended pharmacodynamic effect? The final study that I will show you provides, again, another example of how such a strategy might fail by understanding the reason for the failure can improve the opportunities and the effectiveness of further developmental strategies. So we heard about the viral mimicry response, and a well-characterized driver of this response is hypomethylating agents, demethylating agents, which result in the derepression of endogenous retroviral elements that are that produce double-stranded RNAs that are sensed by the double-stranded RNA sensing system and result in interferon-type response. And this can induce both cell-intrinsic and cell-intrinsic death, as well as extrinsic immune-mediated activities. So based on that concept, which was described by Dr. Daniel DiCarvalho's group at Princess Margaret, a investigator-initiated study combining the demethylase azacitidine with durvalumab was pursued in immune cold tumors with the idea that this could sensitize to immunotherapy. Again, a strategy that is often pursued to increase the potential impact of these therapies in disease types where they are not currently useful. Again, in triple-negative breast cancer, many triple-negative breast cancers are likely cold tumors. This study enrolled patients with ER-positive breast cancer, a subtype of breast cancer where we have seen historically even less activity with immune therapy. And what's shown here is that this strategy did not work. These patients, as we can see, that the percent change compared to baseline was increased in nearly all patients, with only a very small number of patients not experiencing increase in tumor size at restaging. So why did this not work? This study included careful assessment of the pharmacodynamic effects of CC486, this oral azacitidine. And here, showing changes in line 1 methylation, we can see that in the patients treated, here's patients from the breast cohort, with regimen A, which was CC486, or regimen B, which added vitamin C to this, based on evidence that vitamin C could further influence demethylation. We see that the desired effect was not achieved, and thus it's unsurprising that the therapeutic effect of combining CC486 and durvalumab was not observed. Here on the right, we can see the changes in methylation that are achieved in cell lines that respond to azacitidine, and we can see a complete absence of this pattern of changes in methylation in the clinical use of this therapy. So what are the next steps for combining IO therapies and epidrugs? I think it's important to recognize that that clinical translation of strategies that can be demonstrated in the laboratory is challenging, partially because of the obvious complexity of the systems, but also because of the limitations of the preclinical models that are available to us. We know that, especially for breast cancer, there are a very small number of preclinical models where immune effects and immune combination effects such as these can be rigorously evaluated. And they certainly don't reflect the heterogeneity of clinical triple-negative breast cancer that is observed. And thus, rational development for such strategies must consider both this heterogeneity and the context of the disease treatment. In addition, as I hope I've highlighted, pharmacodynamic assessments in clinical studies is essential to assist the interpretation of any results, whether positive or negative, or to interpret differential responses that might be observed between patients who either respond or do not respond to those investigational therapies. So with that, and to summarize, I again probably don't need to emphasize that triple-negative breast cancer is a challenging disease, though fortunately one where inroads are being made. Monotherapy epigenetic drug approaches are likely to require patient stratification in this context, particularly reflecting that the time to treatment effect with an epigenetic agent needs to be considered in the context of the rapid disease progression that often presents clinically. Drug resistance is a major feature of triple-negative breast cancer, and characterization of acquired resistance to our standard therapies, such as in the example of paclitaxel that I described, may represent opportunities to identify new vulnerabilities. And finally, while epi-drug combinations are of significant interest, the toxicity and tolerability of these requires careful consideration as we seek to understand how they may find a place in clinical practice. Thank you for your attention. I'd like to again, thank my collaborators on that work I described at Princess Margaret, and also recognize the contributions of all the other investigators whose work I discussed today.